It's my pleasure to be with you with the AMICRA webinar. I'm Professor Michael Hirschman from Basel, Switzerland, and my topic I'd like to share with you is mechanical versus kinematic alignment, which is a very hot topic. These are my disclosures. So why did we decide for mechanical alignment in the previous years? I think it was pretty clear that mechanical alignment aims for a neutrally aligned leg. That means an HKA of 180 degrees and also a joint angle on the distal femoral angle of 90 degrees and on the proximal tibial angle of 90 degrees. And this leads to a more equal load distribution, avoiding wear of the polyethylene. And that's why in former times it was decided to go to mechanical alignment. So it was all due to longevity of implant materials. So this is what mechanical alignment is. An example of a knee joint. You see, this is a knee joint with a distal femoral angle of 91 degrees, 6 degrees of varus on the tibia makes it together a 10 degrees varus. And if you would align this mechanically, you cut 90 degrees at the femur, 90 degrees on the tibia, makes it a straight knee. Nowadays, we have a big discussion about new alignment philosophies, the kinematic alignment, also adjusted or restricted kinematic alignment methodology. And when you would follow those, you see, you actually reconstruct the knee as it is. You see, this would end up with a 90-degree cut, 91-degree cut for pure kinematic alignment. So it really represents the OA, the pre-osteoarthritic knee. So these are the different alignment techniques in comparison. You can see what you would do to the distal femoral angle and also to the proximal tibial angle, and to which HKA, that means the leg alignment, it would end up. So what is kinematic alignment? Kinematic alignment doesn't look at landmarks in the knee. It just looks at the kinematic axis. And you see that we have different kinematic axes. We have an axis, a transverse axis, the tibia flexes and extends, and you have the transverse axis about which the patella flexes and extends, and then you have a longitudinal axis. And these are very difficult to detect intraoperatively, and this is why this concept is new. This is not really easy to see that intraoperatively. So kinematic alignment actually aims for a distal and posterior femoral bone cuts which were equal medially and laterally. That means you try to reconstruct the knee as it is. What you have to subtract here is the worn cartilage. So you want to be as thick as the TKA components. It depends on which component you use. It's 9 to 11 millimeters. How can you achieve this? You can either use PSI systems as shown here. So you have a planning in 3D on MR or CT, and your execution is then the PSI. But you can also make it more easy. You go for calipered alignment techniques as Stephen Howell is proposing it. And so what you do is you measure your bone cuts and you make sure that the bone cuts on the distal side medially and laterally are the same, and also on the posterior side. So what is the scientific evidence we have currently about this alignment technique, and how is it in comparison to the standard of mechanical alignment? So there are some systematic reviews, and also there is a meta-analysis here of 6 trials. You see 561 patients. The follow-up is 6 to 34 months, so it's very short or midterm follow-up yet. And these are the studies included. So looking at those studies, you see that they report better Oxford scores for mechanical alignment in this sense here, and better KSS scores for kinematic alignment. And when we go further, the WOMAC is better for kinematic alignment. So it's a little bit contradictory. Looking at some more studies, you see here radiological and clinical comparison of kinematic versus mechanically aligned total knees. 60 total knees, 30 in each group, kinematic versus mechanically aligned. And so not a big difference. You see then meta-analysis of kinematic aligned and mechanically aligned knees. No significant difference in complications, change of hemoglobin, length of stay, HKA, joint line obliquity, femoral and tibial component flexion. The most important thing is you need to check what are the knees you have included here. And if you don't have a difference in HKA and joint line obliquity, you mainly have included knees, which you can align normally with kinematic and mechanical knees. So that means neutral knees mainly. Then this is another study, early outcome of kinematic versus mechanical alignment, prospective randomized trial, follow-up 1 year, no significant differences shown with regards to these outcome measures published in Bone and Joint Journal. And then no difference in 2-year functional outcomes using kinematic, another randomized controlled clinical trial. So also no difference. Then you can see that you can have a more deeper look into this data, and then you check for the post-operative limb alignment. You see the HKAs, the hip-knee ankle angle being similar, but more variation in the kinematic. That represents that with the kinematic alignment, you represent or you actually restore more the native knee. And that's also shown in the post-operative tibial alignment. You see 30% are in varus in the kinematic alignment group, and in the mechanical alignment, you only have 4%. So currently there is a big discussion going on about alignment, and the problem is that the definitions are not so clear. So we compare sometimes apples and oranges. We have to go more into detail. What is the current alignment technique? What do you call kinematic here? Some call it differently. Some use more safe zones than others. And I think it's important to be more concise when comparing those. So then another thing, we came up with our knee phenotype concept. And I think this is a very important thing you have to understand, that the knees are entirely different. So we looked up a significant series of non-osteoarthritic and also osteoarthritic knees and compared those in terms of the hip knee ankle angle, the distal femoral angle, and the proximal tibial angle. And what we have shown is that even when the HKA is like the same as in this example, patient A versus patient B, 11 degrees of varus, you see there is high variation, or there could be high variation in the distal femoral angle here, 95 versus 88, and or the proximal tibial angle, as well as the rotational angles. And that means that this is not the same knee, and with the standard mechanical alignment, we treat it all the same, and this has different consequences in terms of how much ligament balancing you have to do. So when you phenotype those knees, you can describe this with the varus HKA. Both have a varus HKA of 11 degrees, but then one has a valgus on the femoral side, the other has a neutral femur orientation, and then both have varus orientation on the tibial side. And if you would make bone cuts here, you see the bone cuts are different because the orientation is different, and so the changes to the laxity envelope is entirely different. And this is actually the way to go. We need to be more personalized. So the discussion about kinematic alignment is a very important one to have. Looking at our data set, we checked how many patients would actually be reconstructed with mechanical alignment, anatomical, restricted kinematic alignment, or pure kinematic alignment. And you see those numbers. Very few patients have mechanical alignment, anatomical alignment, and some restricted alignment. The pure reconstruction can only be done with the kinematic alignment. But is kinematic alignment currently safe, and how far can we go? This is the big ongoing discussion. The tibia is currently not more than 3 degrees varus or valgus indicated. I think that's important to be safe for the sake of our patients. The HKA not more than 5 degrees varus or valgus. So there are safe zones you have to consider for the sake of our patients. And so I would not recommend currently a kinematic alignment, which is purely and really reconstructs some weird conditions, in particular on the tibia, as we know that the tibia loosening might happen with the massive varus on the tibia. I like to conclude my talk. So kinematic alignment is very interesting because it moves us away from more systematic alignment to a personalized alignment. It's important that we should aim more for restoration of pre-wear morphology and phenotypes. The principle of kinematic alignment is that to equal femoral bone cuts in medial lateral side, also on the distal and posterior side. PSI or bone cut measurement is the technique. Outcome is still conflicting, and this has to do with the phenotypes. If you have different phenotypes and put it all together, you're just looking into the fork and you're not analyzing the right knees. I think we need studies looking only at various phenotypes, neutral phenotypes and valgus phenotypes, and then we will find out that we might have less unhappy total knee replacements. Thank you very much for your attention. And it was my pleasure to be with you here. Bye-bye.